Implications and applications of action development to early infant care. Let's start with Nadia Valentini, who has a physical education degree with a master's and doctorate in human science from Auburn University, and 2 postdoctorates, one pediatrics at Southern California University, and other in motor development and learning at the University of Maryland. Currently, Dr. Nadia is a member of the International Motor Development Research Consortium Advisory Committee and is a full professor in Human Movement Science at the Federal University of Rio Grande do Sul, where she coordinates the GAIN research group in motor assessment and intervention. Professor Valentini attended the 2022 conference from the North American Society for the Psychology of Sport and Physical Activity in recognition of her research on motor development. The main focus of Valentini's research is children's developmental trajectories, including investigation of risk and protective factors and motor intervention, with the practical implication of creating opportunities for children to learn in scholarly, clinical, and familiar environments. So, please, Nadia.
Thank you. Thank you for the organization committee, Priscilla and Edson. It's a pleasure to be here after several years that they did invite me. At least I think 6 or 7 years. Just kidding. It's a pleasure to be here talking again about the motor development. I must acknowledge that it's a very interesting public. I think you guys have very interesting questions before, so it's a pleasure to talk with you. So, children living in Brazil, in low-income countries, 6 of 10 children live in poverty. And in general, these children are deprived of several rights regarding education, information, water, sanitation, housing, and protection against child labor. From conception to childhood, children from low and moderate income countries are exposed to several risk factors, prenatal risk, perinatal risks, and exposed also to a diverse outcome during infancy. Some to this factor, for some children, the abuse and neglect that they suffer across the childhood. For these children, early detection and intervention are essential during a period of high plasticity. However, one difficulty of early detection is the rapid changes in neurodevelopment that may mask the signs of delays. Early assessment with valid tools are essential for these children. Furthermore, for several children, the intervention comes late in life when the harm is already established. Nonetheless, the late intervention is still important. But today, we are just going to talk about early intervention. Therefore, today I will talk about the research conducted my group in the Universidade Federal do Rio Grande do Sul. And we're going to talk about assessment, motor trajectory, risk and protective factors, and early intervention for children with motor delays or from low-income families. Assessment is clear a critical part of providing good care for a child. Furthermore, the concept of assessing motor development has taken an even broader perspective in the last few decades, as motor development serves as a mediator for the development of cognitive, social, language, and other domains. In addition, proficiency in motor skills seems to significantly influence academic achievement and also the late physical and mental health of children. Consequently, assessing children's motor development is important for identifying children with motor delays, the soft signs of delays, detect also the changes during the intervention and measure learning, and also determine the intervention effectiveness. Proper assessment of motor development, however, involves the understanding of motor development as a construct. So, in other words, it's much more than a score or a result obtained in a test. Therefore, performance on a specific protocol does not establish a global picture of motor development. It simply demonstrates a level of motor performance in one specific period of time. True assessment of motor development involves the consideration of factors that affect performance and change in the development of motor skills. That brings us to perhaps the most important reason for assessment, that the motor development is much more than a score or a number in the test, but the motor assessment is a window in the grand picture of development. Thus, current research has now shifted towards the study of several aspects related to assessment of motor performance. Aspects of assessment include, but they are not limited to conception and creation of new inventories and protocols, the study of relationships in comparison among them, the extension of investigating aspects of validity in the tests, the adaptation of the test to individuals with disabilities, and the continued emphasis on the importance and use of standardized instruments that can provide a clear picture of motor development status. Therefore, for my group, the first challenge that we have to overcome when I started to research in Brazil 20 years ago was related to assessment and the use of the instruments from a wealthy culture to a low-income culture such as Brazil. My research group has a long tradition on study psychometrics of assessment to Brazilian children. Our research interest beginning for not to know if the psychometrics of assessment developed in an industrialized and rich country would be appropriate for Brazilian children. Therefore, we conducted several national studies assessing large representative samples of the Brazilian population to investigate the test by psychometrics. We have improved the validity of tests of infant motor performance, the Alberta Motor Infant Scale, the Peabody Development Motor Scale, the affordancy in the care environment. We did adaptation for the affordancy for the daycare. And we are now in the process of developing to validate the interaction rate scale, the daily activity for infants, the kit, the knowledge of the parents regarding development, and also the baby scales. Now I presented briefly some the scales that we use in our research and that are validated in Brazil in national samples. The first instrument is TIMP. TIMP is a design to assess preterm and term infants from newborn to 4 months of age. The TIMP assesses the postural control and the movements necessary for motor function. It's a task-specific assessment that demands posture control related to the movement that infant experiences in the daily life, like when they are having a bath, when the mother is changing the diapers, such as this kind of tests. These items have, the items in the TIMP has a high ecological validity, and that is an important strength of this test. For Brazil, our study has shown that the TIMP has high sensibility and strong discriminating power for children with disability and children without disability, and also to catch soft signs of delays. The second assessment, in fact, was the first one that we published the validation in a national sample in Brazil. It's the Alberta Infant Motor Scale. This scale is designed to assess children, from the newborn children up to 18 months. It has 4 subscales: prone, supine, sitting, and stand. It has power to identify motor delays. However, in Brazil, the sensitivity of this scale was established really from 3 months to 12 months. Low sensitiveness and also the decrease in the discriminant power was observed in the 3 months of life and after 12 months. Therefore, our group recommended that when you use the Alberta Motor Infant Scale, in the first 3 months of life and after 12 months, you use another assessment that it has better discriminant power. This is a recent study. We published already two of the validation results. Is the Peabody Development Scale. I'm very excited about this scale because I was kind of skeptical at the beginning, but I'm very excited with the results. It's a scale that is from newborn to 5 years old. It has 6 behaviors subscale: reflex, static balance, locomotor, object manipulation, grasping, and visual motor integration. And it has shown in the national data high sensitivity for children with and without disability. And it's interesting because it's established by a baseline of trial errors. It's very similar to babies, if somebody is familiar with the baby. So it's a very interesting scale to observe changes longitudinally. And the last instrument that I'm talking a bit is the Bailey scale. We use the Bailey scale in the last, I use in the last 20 years, but for a national sample, we are collecting data for the last 4 years. Truly validation studies take a long time. We just talked in the morning, it takes us 4 years to collect the data in the national, in the whole country. So it's 4 years of work in general for 1 or 2 papers, really high demanding kind of studies. We are in the middle of the validation. The data is very interesting. I use more the cognitive language and motor subscales, but I really like that adaptive behavior is another subscale in Bailey. It's very interesting. And our results are shown that Bailey also has high sensitivity and discriminant power, but not in the first 4 months of the life. Very similar to AIDS, but after 4 months of the life, the scale is really nice. So, our validation studies allow us to investigate the motor trajectories across childhood. So, since you have so many data, and I will show some examples of these results. In this early study, we investigated the development trajectory in the first 18 months. It's across cultural studies. We compare our data with 2 higher economies, and we found that the Brazilian children had low scores started 4 months and few independent walking, compared to other countries. When we look at closely at this data, we found out that the difference are not across the whole sample. Brazilian children in the groups at or above the 50th percentile had a similar performance for children from higher economies. However, children at or below the 25th percentile had much lower scores. Just one example to understand those differences. When we found that for crawling, that 6% of the Brazilian children start to crawl at the age of 8 months. And by 11 months, only 60% master this milestone, instead of the expected 90%. Only at 14 months, if you look in the graph, 90% of the sample mastered these skills, this milestone. The same trend was observed for rolling, sitting, and walking, and several other milestones. We observed large wins for skill acquisition in Brazilian infants with long periods of stability in performance. When we look into preterm data, if somebody asks a question about preterm, we also found also in a national sample, 2,000 children, preterm children, we found the similar trends that we found in the previous study with full-term infants. Lower performance in the lower percentiles. The picture over there, the red, the purple, and the black percentiles. Also preterm children, and that's what we have been found, and they have a difference in performance from the full-term children, even when we adopt the correction of the age. And the difference starts about the time that they start to sit. Preterm children have very high difficulty with change postures and high postures. So they have difficulty from postures from low to up and to up to down to the floor, and also to keep control of the trunk in the high postures. So yes, for Brazilian sample, we have differences on preterm and full-term children for locomotor skills. The result shows the need for constant intervention for those children before the acquisition of a sitting position. These national studies allow us to investigate the risk and protective factors for neurodevelopment. We focus on different groups of children at risk in living vulnerability. Keep in mind that all my data is just for children from now, for children living in vulnerability. Not the national samples, because it is having to have a great representation of our socioeconomic status. Now I will present some examples of these data. Our first two examples are studies with preterm babies. In this study, we found that neonatal adverse outcomes, such as leukomalacia and mechanical ventilation, were strong risk factor to explain 46% of the variance in cognitive score, 51 in motor, and 23 in language. However, family income and parents' formal education were a protective factor, explaining 20% of the variance in cognitive score, 21 in motor, and 28 in language. Gestational age and low birth weight, in general, considering risk factor, were not strong and were not strong enough to maintain the model in our data in several studies. So there is risk factors that are more strong, affecting development, just to be born very early or with low weight. And in general are the outcomes. We also look at this factor longitudinally. And here is one example of a recent study. In this study, we found that the delays that we detect at 4 and 8 months predict cognitive, language, and motor development at 24 months for extremely, very, and moderate preterm infants. And that the risk factors were different across these three preterm groups. And that although clinical adverse outcomes explain some variance in cognitive, language, and motor scores, maternal education, siblings, breastfeeding, prenatal care, parents living together, and active play, a very important variable for our areas, were protective factors, explain especially the development of language and motor performance. Another group of risk, and this is not published yet, we had a national study, a populational study in all the prisons in Brazil for children that live in prison with their mother. In Brazil, there is a trend that is similar in the world, the increasing in female incarceration. In Brazil's law allow the mother to stay with the baby until the majority of capitals until 1 year of age, and some other places until 5 years, like in the Paraná is one exception for the national rule. The mother can stay longer with the children. So we are contacted by the Fiocruz to help them to to do a national study with the mothers and the babies. Here is just a little piece of the data that we're still digging in from the babies, not from the mothers yet. We still have at least 1 year or two to analyze all this data. This study is a mixed design, so we have a qualitative and quantitative approach to that. And what we found is that motor trajectory of these infants living in the prisons were very similar to our national data for prone, supine, and subscale. However, they have a high score on the steady position. The data assessment, we also did the data assessment with this group of mothers, showed that the infants were maintained in the standing position since very early for long periods of time, since there is no space in the cells to grow. Regarding opportunities for development, we found 4 different conditions. So we found children that were in the maternal care, restricted to cells with no toys. I know that is something that is beyond our imagination, was at least beyond my imagination for me. Toys are considered in the prisons a weapon, depend of the material. So one of the policies that was generated after this study was that I had to look at the market to see for toys that it could not become a weapon, so that the prisons could buy for the kids. But you have a very even distribution of these 4 conditions. The second condition is maternal care, restricted to the cells and with toys, but they have always less than 4 toys. I know that is also something that if somebody here have kids or is with kids, we have much more than 4 toys for the kids. So, the other condition was maternal care, access to play programs, like kind of if kids could get together 1 or twice a week with the other kids in the same prison, and no toys. And the last condition, the more appropriate, if you can talk about appropriate condition in the prison for a child, maternal care, access to play problem with other kids and toys to play. So, we found that infants restricted to the cell with their mothers and no toys to play had a higher prevalence of delays in growth and fine motor skills, language, cognitive and social development. And as neurodevelopmental delays, of course, was found for infants that they had the toys and opportunity to play weekly with other infants. Now we are also in the middle of a large sample. It's the first time that I conduct a cohort study that has the goal to investigate the impact of intrauterine environment. It's a 5-year study. We finished just before the pandemic, so we have all the data. In this study, keep in mind that it's just a preliminary results. We are just doing the preliminary analysis. We found that mothers that use tobacco or the one, it's also a study in mother in babies, just like the one that I gave the example in prison. So we have the mother that use tobacco more exposed to several socioeconomic risk factors. However, infants of mother with diabetes mellitus and with intrauterine growth restriction show the lower score in supine, sitting, and gross motor skills at 6 months. We are analyzing the data at 4 years old, just a piece of the data yet, and a high prevalence of DCD is also observed in these 2 groups. So, for children, just for the ones from low-income family, we provide that we detect the delays, of course, even soft signs of delays, impairment, delays, and soft signs of delays. We provide intervention. We are able to publish the intervention protocols in several articles, so if you would like to see how we work and how the intervention conducts, I recommended to read these articles. We have very detailed, because it's always a concern about intervention study that the articles do not provide enough information for somebody to do similar studies. So in this protocol articles, we do have all the information. And we also have a recent book on early stimulation for preterm infants that was supported by the Bill and Melinda Gates Foundation. I'll talk about some of this data later. Our intervention have different protocols depending on the study goal and also depends on the level of impairments of the children. So our sessions, we had some intervention that the session was 15 minutes, 3 times a week. You have intervention that is 45 minutes. So you have studies that we have intervention daily. Have different kind of dose for the intervention, and we also measure this dose of the intervention. It also, we have been in the beginning, have the intervention delivered only by a professional, like a master or PhD student, or even I delivered several of these interventions. And later on, we are empower the families to deliver the information. So try to extend our capacity of promoting development by empower the families. So we can look intervention. Some interventions are individual in the home, and if we look at this picture, not necessarily the places that we go are safe or are the best picture or the best conditions for development. So we deliver the interventions at the home with individual care. Here are some examples. More examples. I picked this picture purposely because if you see in this picture, we are intervening with the baby on the parent's bed. And that's what happened several times on these low-income families. The more appropriate place, the more safe place is the bed of the parents. So it's at the beginning was something that was difficult for us, and we got used. And so here a typical example where we are delivering the intervention. So we also use daycares. We intervene in daycares individually. We also now are training the professors in attending daycares to deliver the intervention. And we try also, again, to try to extend the potential of the intervention, delivering small groups in daycares, in foster cares also. So groups of 4 or 5 infants. Foster care, we have individual and groups intervention. So now I will show some results of this study very briefly. Our first intervention studies were conducted individually at home, and they cared by trained professionals, like I told you, physical therapists, nurse, physical educators, so different professionals. The results in several studies have shown positive outcomes for gross fine motor skills, social interaction, receptive language, expressive language, and memory. And many of the results are maintained in the follow-up longitudinal studies, so with different intervals of follow-up, a month, 2 months, 3 months, and 6 months. Now we are doing follow-ups a little bit larger than 6 months. After several individualized intervention studies, we attempted, like I said, to maximize our intervention effort by conducting small group intervention in daycare in foster care. And here is one example of these results. We did this, we have 3 intervention groups in here, individual at the home, individual at the daycare, and also group at the daycare. And our large effect size were the 2 groups in the daycare, individual and groups. It seems that the teachers in daycare were more willing to implement it, have more time, and maybe understand better the intervention goals than the mothers in the home care. A more recently study, we trained the parents, the caregivers in the foster care, and the teachers in the care to deliver the intervention. This is published, I think, two years ago. It's a randomized control trial. Our experimental groups are a combination of a parents deliver the intervention 4 days a week and a professional deliver 1 way. These are, in general, they are all experimental groups, but we have 2 different conditions. One condition was the parents 4 days and the physical therapist 1 day. And the other condition was just the parents the 4 days. So, as you can see, the results show positive changes in gross motor skills for all infants at the 3 different contexts: daycare, home care, and foster care. You can see that the foster care was the group that we found children with more impairments. And we also found in this study positive changes in maternal practice for all the conditions. Mother and caregivers exposed infants to more demanding positions and challenging tasks from pre to post intervention. And we also found that the parents and caregivers at the home in foster cares adapted the home environment to provide space for infants to play and free access to gross and fine motor cores. The parent and professional combination protocol was more robust to promote development change and also changes in the context of development. Another example, this is not published yet, is submitted, is the randomized control trial with preterm babies supported by the Gates Foundation. This is a longitudinal study. We are going to just see the data, this preliminary data in the first year, but we are follow up these children until 42 months of age. So this is just the first phase of the study. Overall, intervention groups show higher cognitive, language, and motor scores at 4, 8, and 12 months. And the effects were maintained until 18 months. I forgot to mention here that this intervention we start very early. The early age of intervention I had done in 20 years. We start after 48 hours in the neonatal intensive care. So, and then we train the parents to deliver 10 months of intervention. So we went to the homes with a multidisciplinary team and trained the parents to deliver every month. They receive a book with all the tasks, all the goals. They have to provide information how long they did during the day. It was very complex design. But parents delivered the intervention after the kids were discharged from the neonatal intensive care. But during the time that they were in the neonatal intensive care, we are in charge with delivering the intervention. So we also found, and that is something that I've done in the last year, I want to really look closer to the family and the interactions. We are using instruments that I told you before that we are collecting data to see if it's validated in Brazil. But we have some preliminary results, and we found positive changes in child-mother interaction regarding children's autonomy, responsiveness, empathy, and motor and emotional self-regulation, the first part of the picture. And we also found changes in mother sensitiveness, responsiveness, respect to the child autonomy, and cognitive fostering. Although the intervention effects are persistent until 18 months, it is important to highlight that it was less intensive. What did this tell us? That preterm infants need long intervention periods and constant intervention periods until probably across the childhood. So, we have been aware of the need to translate our research to practice. We have done that in books and book chapter. This is the book for early stimulation. It's in 2 languages, Portuguese and English. supported by the Bill and Melinda Gates Foundation. It's a collaboration with the Hospital de Clínicas de Porto Alegre. I have been there in the follow-up for the last, clinic for the last five years. We also have a smartphone for program for collecting contextual information about infant daily life. We framed using the ecological momentary assessment paradigm, and we are in the middle of the process of developing an app that can support parents for their intervention. We already developed 2 apps for older children. Now we are in the middle of the app for the youngest one. To conclude, my line of research has been used a framework, the bioecological paradigm, to try to better understand the proximal process and the factors that affect the child life. Thank you.